Hello, it's early November, and this is episode 3 of Ask the Pearl from the Pearl Women's Center in Portland, Oregon. I'm Dr. Drs Fogelson.
And I'm Dr. Drs Rosenfield.
And this is a web series coming from the Pearl Women's Center where we are discussing common issues in obstetrics and gynecology and women's health that are of interest to our patients and people around the country and the world.
And we just want to say thanks because apparently we are getting some traction. We've noticed the number of views has really started to go up, and we're getting comments, which is great. So we can now base some of our episode topics on the questions that you guys are asking, and that's what we're going to do today. What are we going to talk about, Nick?
Well, we recently got a series of comments from one of our patients here in the office, and she was asking about breast cancer screening guidelines because it's gotten a little bit confusing. A lot of the guidelines that we're dealing with have changed over time, including the pap smear guidelines that we talked about at the last visit. And today we want to talk about the mammography guidelines, which is breast cancer screening. Interestingly, a lot of things have changed over time, and we have started to recommend that breast cancer screening is a little bit less often than it used to be.
And this is one of those things that when an announcement happens, the media oftentimes will really focus on one particular item, and it'll hit the national news, and then we get a flurry of patients calling because they're concerned. This particular one was about the screening mammography, which is the X-ray study that we hope would detect breast cancer early in its development in patients. And the recommendation guideline that it changed was going from starting at 40 years old to starting at 50 years old. Is that right, Nick?
Right. So, again, we used to say everything used to be simple. It used to be you get a mammogram when you're 40, you have one every year until you're dead. Then you stop having mammograms, obviously. It used to be you get a pap smear when you're 18 years old and you get one every year and you get one forever. Well, now it's getting more complex. And it's getting more complex because we're understanding the disease processes more and more, and we start to understand how long it takes to go from a little cell of breast cancer to a clinical disease that could actually hurt you. And once a year is a very convenient time to think about, but something I said in a previous episode, a year is the amount of time it takes the Earth to go around the sun. It doesn't have that much to do with human disease. And so the question becomes, is once a year really the appropriate time? And so now we have 3 new guidelines, and we have a bunch of different bodies that have made these guidelines. We have the guidelines of the American Cancer Society, we have the guidelines of the American College of Obstetricians and Gynecologists, and we also have the guidelines of the United States Preventative Task Force. And wouldn't it be great if they were all exactly the same? But are they all exactly the same?
No, they're not.
No, they're not.
So one thing we always want to talk about is what is the motivation behind some of these organizations and their recommendations, and what's the science behind it. So let's start with the science.
Sure. Let's start with the guidelines first of all. What are the guidelines? So the American Cancer Society has rolled back a little bit. Rather than saying every 40 years, they recommend, based on reasonable evidence, that you can start doing mammography screening when you're 45 years old and have a mammogram every year. And they say once you're 55, you can get a mammogram every 2 years. And then they also say that if you get old enough that you're probably not going to live more than another 10 years, that you can stop getting mammograms entirely. And so that's a little different from where we used to say get a mammogram every 40 years. Now, ACOG, which is the American College of Obstetricians and Gynecologists, they're holding on to the old statement. They're saying get a mammogram at 40 every year. And then the USPTF is saying what?
I believe the USPTF was saying offer it. Is that right?
The USPTF is saying at 50. We just read it. So we'll read it again. That the USPTF is saying at 50 starting to get mammograms.
This is right in front of us on the screen, by the way.
Yeah. So, but it's behind the part where we can see us. So it's a little bit hidden, but I read it. So it's at 50. So even as physicians, it becomes confusing when patients ask us questions. How often should I get a mammogram? You start saying, oh gosh, because I have 3 different recommendations. Which one should I stand by?
And even then, there were recommendations that you would take if you had a first-degree relative like a mom or a sister with breast cancer. You take the age of their diagnosis and subtract 10 years, and maybe that would be the time that we would get a mammogram. There used to be ideas on baseline mammography as well. All this is changing, but I think stepping back and taking a bigger picture is an interesting place to go for a moment, which is, why do we do a mammogram? Okay, so you're getting an X-ray of the breast. The reason that we don't do this in younger patients is that the breast tissue is dense in younger women. It's thicker, which means that when you take an X-ray, you can't see through the tissue very well. And what we're looking for is a very small lesion that oftentimes looks like a calcification, and on an X-ray that looks like a white dot. So what happens is, as you get older, it's easier to see these things develop, and that's why the screening originally wasn't for younger patients. Also, looking at the incidence of breast cancer is something that increases as you get older.
Right. And, interestingly, you would think that the earlier the better screening, because the earlier you'd be able to detect tumors, but the problem is that when you're young, the mammogram doesn't work very well because the breasts are dense, and furthermore, the frequency with which you might find things that aren't cancer starts to go up. There is a fallacy that a lot of people have that more screening is better, because you think, well, why wouldn't you want to find things early? The problem is that no test is perfect. All tests have a concept of sensitivity and specificity, and it's a little complex, but sensitivity means how likely am I going to pick up someone who actually has cancer. So if the woman has cancer, how likely is the mammogram actually to find it? Specificity is kind of a weird opposite, which is basically when a person doesn't have cancer, how often is the test going to say that they don't have cancer? And the importance of that is that if you have really high sensitivity, that means you're going to pick up everyone that has cancer on the mammogram. If you have really high specificity, that means you're not going to have a lot of false positives. And because the test is perfect, it's not perfect, and of course no tests are perfect, the more and more and more you do screening tests, the more opportunities you have to find a false positive. So if I do a test on a younger woman who's more likely to have some benign breast lesion that's sort of meaningless in her life, but I find it and then I go, oh gosh, I don't know what this is, maybe it's cancer, then I send her to the surgeon or the interventional radiologist, and she gets a biopsy and they go, oh, it's not cancer. Well, I've kind of caused harm to her because I freaked her out, first of all, because she's found this thing that's going to cause a tremendous amount of anxiety until she finds out it's not cancer. And you've probably spent several $1,000s on additional imaging and a biopsy and so forth. So if the research were to find out that we find hundreds of those false positive events for every one cancer we find, at some threshold we would decide it's not worth doing the test anymore. And that's why they some of the recommendations have pushed back to 45 years, because they're suggesting that between 40 and 45, you have such a strong likelihood of finding a false positive over finding a cancer that it's better off just not to know.
The problem with that, of course, is the patients that we have, the friends that we know, and the relatives that we have as well that have been diagnosed with breast cancer at that earlier age.
Right.
And the reason that they were diagnosed is because of mammography. And this is where we kind of need to get back to being doctors rather than looking at only statistics.
Got to individualize care.
Yeah, and this is what we always talk about. And when we talk about things like hormone therapy and birth control, et cetera, we want to individualize the care. But I think more importantly is recognizing that if you're the patient that gets diagnosed with cancer, that you're no longer a statistic. The 1 in 8, the 1 in 84, the 1 in 10,000. These are numbers that we throw around in our office about things like ovarian cancer or cancer of fibroids or breast cancer. But these numbers, when it's you, it's 100%. Right. So it's really important for us to look at what is the best way, based on your own personal history, based on your family history, for us to manage you as a patient. And I guess luckily for us, we now have a couple of different guidelines that we can look at. And Nick and I were just talking about before the podcast this idea that there's a recommendation perhaps that we even move away from the clinical breast exam, which most patients would be familiar with, which is the actual physician coming in and doing a clinical exam, because the claim is that we seldom are finding a malignant lesion. But at the same time, that is an opportunity for us to do a skin exam and look for things like a melanoma or a basal cell dermatology type of problem. But both of us have felt masses in the past, and we wouldn't feel comfortable giving up that clinical exam. So we have to look at the guidelines as guidelines, not as rules, not as laws, and go from there.
So, yeah, I completely agree. I mean, there's even discussion in pelvic exams that's published by the primary care literature, which are family physicians and internal medicine physicians, that you don't have to do a pelvic exam anymore. They still recommend a pap smear, but the part where you actually do a manual exam with a few fingers in the vagina and you feel the uterus, they're saying, well, that's not useful. But, I mean, there's just countless times in my career that I found very useful information, even on a screening pelvic exam. And part of it's because I'm a gynecologist. I'm really good at it. So if you put me up against a family physician who doesn't see as many abnormal pelvic exams and doesn't really know what abnormal feels like very often, they may miss something that I pick up. And so I am very skeptical of a recommendation put out by the American College of Family Physicians saying I shouldn't do a pelvic exam, because I'm like, I've done lots of pelvic exams that turned out to be positive. And in fact, I've had patients recently who had significant findings who just months earlier had a, quote, negative pelvic exam by, honestly, a less skilled examiner. So it's difficult when you look at these guidelines that say, don't do this anymore. You don't know who's doing the exam, you don't know who's reading the mammogram, you don't know a lot of things. But just in general, I think we can be safe to say that if you want to get a mammogram at 40 every year, there are guidelines to suggest that that's a reasonable thing to do. If you want to wait until you're 50 to get mammograms, that's also a reasonable thing to do. If you want to start getting mammograms at 45 and have them every year, that's a reasonable thing to do. Any one of those things is probably a reasonable way to approach it. We do have to individualize it. We have to consider who the patient is, and we're talking about average risk patients. If your mother had breast cancer, if there's ovarian cancer in your family, if you've had other breast biopsies, these all things have to go into it. So you have to talk to your physician, whether they be an OBGYN or Rick or I or whoever. You have to say, how often should I get screened? And then take all this into account, talk about your values on screening and medical intervention and all this kind of stuff, and then decide what's right for you.
Two additional things that I think are important to mention. One of them is looking at some of the other modalities of detecting breast cancer that are out there. There are things like an MRI that actually do a phenomenal job at detecting breast lesions and categorizing them. But the problem is that if that was something that was offered to all patients in a screening type of situation, the cost of healthcare would go up so high that no one would be able to afford it. So we need to look at that as a reality. So that's why we use the mammogram. Now, breast MRI, if you do get approval for that by insurance, or if you're able to afford to pay for that yourself, is an excellent modality. There are some other interesting imaging techniques, including 3D imaging, that are out there and being investigated.
Thermography is a good thing too.
Thermography has not really been all that great as far as the radiologist, but maybe the technology is getting better.
It's interesting, but it's not covered by insurance right now, and I think it's probably not going to pan out. The thing about breast MRI is that it's being used wrong in some cases, in my opinion. I've actually ended up reviewing a lot of this literature because I've reviewed for insurance companies on this, that people that have very, very high risk of breast cancer benefit from breast MRI. That's people that have BRCA mutations, which is the ovarian and breast cancer mutation. They benefit from MRIs because those people are very likely to get cancer in their life, and the MRI finds it when they're really early. And in fact, some of those people end up having mastectomies, like Angelina Jolie was in exactly that situation. And she could have had breast MRIs every year to find the cancer when it happened, because it would almost certainly would have happened eventually, but instead she chose to have her breasts removed, which is a whole other topic. But in that person who has an extremely high risk, MRI makes sense. What doesn't make sense is a way that MRI is being recommended, and radiologists sometimes recommend this, and they shouldn't, and that is that when you have a mammogram that shows a lesion that is concerning, that in the absence of MRI would have led to a biopsy, they say, let's get a breast MRI. And the insurance companies won't pay for that because they shouldn't, because the problem is that the MRI at this point is not good enough to take a lesion that is concerning for malignancy and say it's not cancer. And for that reason, it's a waste of money. Really, you should just go and get the biopsy and not do the MRI. And radiologists often recommend things. We all have our own biases, and they may recommend things that send imaging back to their own business. They may not realize that bias exists, but it does. And so getting a breast MRI because you had a mammogram that was concerning probably isn't the right thing to do. But getting it because you're really high risk in the first place very well may be the right thing to do, but you have to talk about your doctor. It's very specific.
The last point I think that we ought to just bring up is that the reason for some of these modifications is not necessarily detection of disease, but prevention of death. So just be aware that if an organization makes a recommendation, and this really holds true not just for mammography, but for other screening, it might be that they're looking at an entire patient population and looking at a death rate. And if they don't see that the death rate has been significantly changed by a specific test in a specific age group, then the recommendation may change, even though there might be detection that's occurring. So it's something that is been debated. There'll be a lot of people that will be very biased about this, but hopefully the information we've given you during this podcast, whatever we're calling video blog, will be useful for you. And if you ever have any questions, you can always contact our office. You can email us through this format, and we're happy to take your questions and look forward to future topics from you, about you, and to you. So
that's right. You'll see the little email and everywhere that you can contact us right here, and please keep sending the questions. My office is getting nicer. I got up some pictures. If you ever come and visit our office, it's the nicest gynecology office I've ever experienced in my life. It's part of why I came to work here. I added to it with an original Alexander Calder right there. And I actually have some books on my shelf now, so things are getting better. So thanks so much. We'll see you for the next episode, and please send your questions for what we should talk about next. Thanks again.